airway obstruction. Complete obstruction, as you know, is life-threatening. Partial obstruction, we need to make sure we get the obstruction out, whatever it is, whether it's partial or complete obstruction. How will the patient behave or look if they have an upper airway obstruction, like a sudden airway obstruction in a restaurant? They're going to panic. The universal sign that you're choking. What else? They can't talk. All those things from CPR that you learn. They're not going to look like a happy camper, right? They're going to need immediate assistance for you to help them. So upper airway obstruction is obstructed airflow through the upper airway, which is the nose, the mouth, the pharynx, and the larynx. Often the upper airway is occluded by the tongue. So upper airway obstruction can be partial or complete. Lower airway obstruction also can be partial or complete occlusion of the trachea, the bronchi, or the lungs themselves. So if you have any kind of airway obstruction, you're going to have that anxiety, that restlessness. The patient will be dyspneic or be short of breath and have difficulty breathing. You may hear abnormal breath sounds. They may have obstruction due to a lot of mucus, a mucus plug, for example. A patient has a trach. May have fluid in their lungs due to congestive heart failure. So patients who have any sort of airway obstruction problem, you need to attend to that immediately because you have very little time when a patient's airway is obstructed to maintain their gas exchange and oxygenation to the brain and vital organs. So just a picture, just to remind you what that upper airway looks like. You already had this in anatomy, so it's prior learning. Okay? So what are some of the causes of upper airway obstruction? Tongue edema. What would cause tongue edema? Allergic reactions, yes. What's that called? Anaphylaxis. Laryngeal edema. What would cause laryngeal edema? Infection. Esophageal varices are in the esophagus, not in the airway, right? It's GI. Okay. What else? Anything else cause laryngeal edema? Intubation. Yes. Head and neck cancers, cerebral disorders, facial or neck trauma, burns to the head and neck, the swelling due to the burn. We already mentioned the anaphylaxis. The most common cause of upper airway obstruction is that tongue. Also peritonsillar and pharyngeal abscess, very thick secretions and mucus plugs, smoke inhalation edema, or foreign body aspiration. We see more foreign body aspiration in children than we do in adults. How about the lower airway obstruction? Here's all obstructions of the lower airway. So you should be able to identify which structures are upper or lower airway. So if you have a lower airway obstruction, what do you think could cause that? COPD? How does COPD cause lower airway obstruction? Chronic obstructive pulmonary disease. Smokers may have COPD. What causes the obstruction? Ash in the lungs with COPD?
Oh, no, I mean from smoking.
From smoking. I don't think it's ash in the lungs.
What is
What happens? Yes, COPD. What does smoking cause to your, what does it do to your lungs?
Cancer.
Causes cancer. The gas exchange is tremendously impaired. Okay? But how, if you have COPD, how does that cause an obstruction? Or emphysema? Pulmonary embolism, that's in the vascular system, which prevents blood flow to the lungs. But it does not cause lower airway obstruction. Yeah, the airway obstruction for COPD is probably the secretion. And the alveoli are stretched and don't recoil? Absolutely. How about asthma? How does asthma cause lower airway obstruction? Constricts the bronchioles, constricts the airways so they have very narrow passageways for the air to flow through. Cystic fibrosis? Increased mucus, yeah. Foreign body, I think, is self-explanatory. The secretions associated with cystic fibrosis, COPD, and emphysema. Pneumonia, how does that cause lower airway obstruction? Is it bacterial pneumonia? The alveoli are filled with, as a result of the bacterial fluid. Okay? TB, because it causes obstruction and it causes cavities to form in your lungs. What else? Okay, and then the last one on your list is pneumothorax. What is a pneumothorax? Pneumo means lung. You can have a hole in your lung. Pneumothorax is a collapse of a part or a complete lung. Okay? Okay, so if you have anyone who has any problem with airway obstruction, rapid assessment is very, very important. And rapid assessment, this is part of your CPR, means you need to open the airway with positioning. How do you position an adult's head? You hyperextend the head to open the airway, right? And sometimes, if the tongue is occluding the oropharynx, just opening the airway by tilting the head back will pull the tongue away from the airway and actually open the airway. If you're in a hospital, you would insert an oral airway, suction secretions if need be, perform the Heimlich maneuver if the patient has an occluded airway due to an inhaled foreign body, and you need to be able to assist with emergency procedures at the bedside. That tracheostomy is misspelled, I just realized. The cricothyroidotomy, the tracheostomy, or endotracheal intubation are some of the interventions that we will provide in acute care. Okay, so now let's just basically look at what the mechanics are of breathing. Breathing is spontaneous. Do you think about taking your next breath? No, so it's very spontaneous. The breathing is you don't think about it. It is not anything that is something that causes difficulty for you if it's normal. So respiration is the movement of air in and out of the respiratory tract. Your inhalation or your expiration is twice as long as your inhalation. So it's 2 to 1. So inspiration or inhalation is the inflow of air into the lungs. Okay, and then expiration is the movement of gases from the lungs to the atmosphere. So the exhalation is removing the carbon dioxide from your lungs. And your breathing, your respiration is affected by the position, your activity, your disease processes, and any other problems that you might have with your respiratory system. So less than 5% of your total energy is needed for normal breathing. When you're exercising, up to 30% could be of your total energy could be used in the work of breathing. The patients who have like COPD, those pulmonary disorders, that picture that I showed you in module 3, I think, that very cachectic looking older gentleman who was sitting at the bedside, that's a typical picture of someone who has COPD. So those patients are so thin because all of their energy is used to breathe. And if you have such difficulty breathing, it's hard to eat when the priority is breathing, and you're working so hard to breathe, it's really hard to get adequate nutrition in. So they usually look pretty frail and cachectic. The normal respiratory rate is 12 to 20 breaths per minute, and it should be very normal, easy breathing without any sort of major effort. There are different types of breathing that we can do. Classical breathing is thoracic breathing, and you can actually, if you put your hand on the patient's chest, you can see the chest moving up and down. You can count the respiratory rate. The other type of breathing is diaphragmatic breathing. Diaphragmatic breathing takes less effort because it involves the diaphragm, and the diaphragm is a very large muscle of breathing. That diaphragm allows the lungs to expand more fully if you're using diaphragmatic breathing or abdominal breathing. A patient who has COPD or has difficulty breathing, they don't have to have COPD, we often teach them pursed lip breathing. And pursed lip breathing is breathing in through your nose for about 3 seconds, and then exhaling through pursed lips like you're going to whistle. So, deep breath, hold it for a few seconds, and then blowing it out as though you're whistling. That allows the oxygen to be in contact with the alveoli for a longer period of time, thereby promoting better oxygenation in patients who have problems with oxygenation. Okay, so what regulates our breathing? The respiratory center is the medulla oblongata in the brain and the pons, and chemoreceptors respond to changes in CO2 levels and the level of hydrogen in the blood. So blood gases, if we are taking blood gases, we would look at the CO2 level as well as the oxygen level and the pH of the blood. When we are looking at blood gases are always arterial. So it's not like the lab's coming in poking a vein. Blood gases is blood taken from an artery. The function of the lungs, your lungs regulate arterial oxygenation and carbon dioxide elimination. And it's just also automatic when you don't have respiratory problems. So lots of this is terminology and a little bit of the physiology of breathing. So respiration is also called ventilation. So we have ventilation, which is the air flow. And it's a process of gas exchange between the individual and the environment. The air you're breathing in is ventilation. Okay? So respiration has 3 parts. Ventilation, which is airflow. Diffusion of the oxygen of the gases so that there is blood carrying oxygen capacity to all parts of the body, all organs and all tissues. And then the perfusion is the transport, the blood flow, the transport of those gases. So ventilation is the airflow, perfusion is the blood flow carrying the oxygenated blood. You have to have all 3. If you have a problem with, or tell me what kind of issue would cause ventilation problems. If you're looking at the 2, ventilation and perfusion, what could cause ventilation problems in a patient? What kind of obstruction? Sinusitis is upper airway. So we're talking about really gas exchange, air exchange. So ventilation. The ventilation, the what?
Tracheomalacia.
Tracheomalacia. What is that?
When the tracheal has this, it grows abnormally, and it's basically an obstruction.
Yeah, it becomes very, very narrow. So you could have ventilation and perfusion need to be matched. So if you have a patient who has bilateral pneumonia and their lungs are pretty well filled with fluid, there is not an opportunity for gas exchange. So that patient would have a ventilation problem. A perfusion problem would be that pulmonary embolus that I think, Hun, you just mentioned that. If you have a pulmonary embolus, a blood clot in your pulmonary blood vessels, then the lungs cannot pick up the oxygen because the ventilation is there, but the perfusion isn't there to pick up that O2 when the gas exchange takes place. So if you have ventilation or perfusion problems, they need to be matched at all times, but ventilation can occur for a short period of time without perfusion, and perfusion can be limited for a short period of time with with good ventilation. So you can have one without the other for a very, very short period of time. Okay, taking a look at each one of the specific assessment items that we look for in respiration. Eupnea is normal breathing. You need to know these medical terms because you might see them in a question. You need to know what that means. So eupnea is a respiratory rate of 12 to 20. It's a normal rate, and eupnea means there's a normal rhythm, and depth and effort is all normal. Tachypnea is a respiratory rate above 20. And you can have tachypnea due to blood loss. If you have blood loss, you have less volume in your vascular system. Therefore, the heart's going to compensate by beating faster, and the respiratory rate is going to increase to collect as much oxygen as the lungs possibly can extract. So tachypnea can occur also due to stress. People who are very, very anxious, maybe pre-op patients, they, due to stress, may have a very rapid respiratory rate. Fever increases your respiratory rate as well as high altitude because the oxygen concentration in the air is less than at sea level. And then we already talked about disease processes like COPD, pneumonia, and exercise would increase your heart rate, your respiratory rate as well. Bradypnea is a rate of less than 10. And in most hospitals, if there is a rate less than 10, they may have some standing protocols. If the patient is on a post-op unit, they may have orders that you would implement if the respiratory rate drops to less than 10. Could be medications. What medications would cause the respiratory rate to drop to 10 or less? Morphine, so narcotics, hypnotics. Anything else? Sedatives, right? I'm sorry, what did you say? Depressants, yes. So any drug that has a tendency to decrease the respiratory rate, you need to watch those side effects very carefully. Sometimes patients have neurologic disturbances with head injury patients. Their respiratory center may be affected, so they may have a respiratory rate that starts to drop to the levels where they may have to intubate the patient and put them on a respirator. Electrolyte imbalances after anesthesia and hypothermia, having a very low body temperature, will all cause bradypnea. Apnea is A in front of a word always means without. So without any breathing, absent respirations, it may be periodic. If it's periodic apnea, what's that called? What's that respiratory pattern called? Change dose, yes. We also have patients who have sleep apnea. So they may wake up many, many times during an hour of sleep and stop breathing. Then they'll wake up, take a deep breath. Often patients snore significantly as well when they have sleep apnea, and they will just stop breathing for sometimes prolonged periods of time and then take a deep breath and then sleep again. Can cause major health problems. So a lot of people who have sleep apnea have what they call a CPAP machine, continuous positive airway pressure, to keep that upper airway open. If you have a patient who develops apnea, it's also called a respiratory arrest. What are you going to do? Okay, code blue, but what are you going to do besides calling a code blue? You're at the bedside and you notice this patient had sort of a low respiratory rate, wasn't real responsive. Patient had pain medication on board, came back from the recovery room like 3 hours earlier, and now you're looking at him and suddenly you notice he's stopped breathing, he's apneic. What are you going to do? ABC. So what are you going to do? What's the first thing you're going to do? Open the airway, right? Tilt the head back and bag him. Every hospital bed has an AMBU bag. Okay? So it's your job, because you're CPR certified, not to just run out and call for help, which you would probably do anyways. You need to call for help but not run out of the room. You need to stay with the patient, open the airway, and ventilate them. So if you can't remember how to use that ventilator bag, practice it in the skills lab. All of the heads of the bed at the head of each bed, there is an ambu bag with a face mask. So practice how to hold it in place and then squeeze it to promote ventilation for your patient. You all need to know how to do that. And every semester we have some situation in almost every clinical group where either the patient, we've already had in long-term care where a patient died, where a patient was resuscitated, and many of you will come across a patient that needs resuscitation of some sort. If they stop breathing, it's your job to immediately jump in there and breathe for the patient using that ambu bag, okay? So you can't just panic. You all know how to do CPR. Somebody will be there within seconds, but you can't run out of the room to call for help. So in most cases, you can call, if you pull the call light out of the wall, it'll not only make the call light go on, but it'll make that emergency light go on that you need immediate assistance. Most call lights are answered pretty quickly, so if you can't think of that and you turn the call light on, just ask that send everyone to your room, and they'll know where you are. So you need to, if the patient's apneic, institute interventions immediately. How much time do you have, max, before the patient's brain dead? 7 minutes, that's a long time. How long do you have? 3 to 5. And if you're closer to the 3 minutes, that's better than the 5. Okay? So we looked at, I think you've seen this slide before, some of the respiratory patterns. So we all know what regular breathing looks like, and then some of the irregular respiratory patterns. So if you have a regular breathing pattern, you can have eupnea, tachypnea, and bradypnea, right? But if you have some of these others, look at the one at the bottom, the BIOS pattern. The BIOS is very faster and deeper than normal breathing, and then it's followed by slower respiration, alternating with periods of apnea. So if you see that little straight line on the bottom just above the word irregular, that's a period of apnea. We see BIOS often in patients who have increased intracranial pressure, those head injury patients. Patients who mostly have neurological problems will have BIOS respiratory patterns. The next one on your list is the Cheyne-Stokes. It's a breathing pattern that is it's faster and deeper than normal, and again, it has slower respirations, and then it has periods of apnea. And those periods of apnea, if it's at the end of life, keep getting longer and longer, and the periods of breathing get shorter and shorter. And so we'll see Cheyne-Stokes at the end of life in overdose patients and those neuro patients, the increased intracranial pressure type of patients. The other one that's on your list is apneustic breathing. Again, I don't have a picture of that rhythm, that pattern, but apneustic breathing is prolonged gasping inspirations followed by very short expirations. We already know that expirations are normally twice as long as inspirations, so it's kind of reversed. We see that in central nervous system disorders. Okay? So now we're going to look at respiratory. We just looked at rate. Now we're going to look at depth of respiration. So a normal breathing is, you can just tell that the depth of respiration of your patient is normal. Shallow breathing is not very great chest expansion is occurring. And shallow breathing causes tachypnea because the body's responding with a shallow breathing and have less gas exchange. So the less air you take in, the more rapid you're going to breathe to compensate for the decreased oxygenation due to the shallow breathing. So tachypnea is usually rapid and very shallow because the faster you breathe, the less time you have to get enough air in as well. So it's kind of a vicious cycle. Hypoventilation is also occurring with shallow breathing, and hypoventilation means that they're not getting adequate gas exchange. We see shallow breathing and hypoventilation in patients who have had a significant amount of narcotics on board. And so when you have a decrease in the depth of respiration, which occurs with the shallow breathing, you have impaired gas exchange because you can't oxygenate as well as if you were taking a full breath. Deep breathing is an exchange of very, very large volumes of air, very deep breathing. Those Kussmaul respirations, those are very rapid, very deep, and those are seen in patients who have very, very, very high blood glucose levels in diabetic ketoacidosis. And you can actually, those Kussmaul respirations also are kind of fruity smelling due to the diabetic ketoacidosis. So very rapid, deep breathing, air hunger, like they can't get enough air in. Hyperventilation, plain old hyperventilation, is often seen in patients who are very anxious. So if they're hyperventilating due to anxiety before they go to surgery, they're blowing off too much CO2, right? So how do we usually address hyperventilation, that really deep breathing? Breathe into a bag. And if you don't have a bag, what can you use? A what?
I've seen people breathe into their hand.
Into their hand. What else would you have handy in a hospital? What's at the bedside I just mentioned? That ambu bag. Take that mask off and have them breathe into the mask. And that often will help. If you have a paper bag, those little paper trash bags that sometimes hang on the side of the bedside table, that would work too, but don't use the plastic ones. Okay? So hyperventilation is abnormal, prolonged, deep respiration. Okay, the next one, we're going to take a look at effort. Normally, breathing is effortless. It's evenly spaced, and the breathing that you do is very even, and very, very little in depth. So as far as your breathing is concerned, if everything is normal, the patient has no complaints, they look absolutely normal, their color is good, and you all recognize normal breathing because that's what we normally do. Normal in older adults may vary a little bit because lung compliance diminishes with age. What causes that diminished lung compliance? The what? Yeah, loss of elasticity of the alveoli. What else happens in older adults? What happens to the rib cage? It stiffens and less expansion, and it becomes more rounded. What was that called? Barrel chest, okay? So if you have an older adult, their normal breathing may look very normal if they're not sick, but they very quickly are compromised because of their decreased lung compliance, the diminished respiratory residual that they have in their lungs. So you have to keep an eye on your older patients at all times. Dyspnea is difficult or labored breathing. Dyspnea is very subjective. Dyspnea is not objective. So if you think your patient's dyspneic, you have to ask the patient if they have difficulty breathing. Dyspnea is subjective. Okay? So dyspnea is difficult or labored breathing. Sometimes I've had patients who looked like they were in severe respiratory distress, had long-standing COPD, emphysema, and I would say, "Are you having difficulty breathing today?" And the patient would say, "No, I'm good." So he was sort of status quo at that point, not any worse than it was before. And so in that patient's mind, he was okay. He was managing fine. So dyspnea, you have to ask the patient. So if you're going to chart that the patient's dyspneic or looks like they have dyspnea, you need to ask the patient. If they have dyspnea, they will have nasal flaring. There are objective things that you can actually identify in your assessment. They would have nasal flaring. They're trying to get enough air in so you actually see the nares flaring out, trying to get maximum amount of air. Especially in younger patients and in children, you'll have sternal retraction or retraction of the tissue between the rib spaces. Patients who are dyspneic always have an increased heart rate, and they may have that funny gray look, or they don't look so good. If you have a patient you can't really put your finger on, they don't look so good. Assess them very carefully, and perhaps who could you call to assess that patient? Respiratory, you could call them, and they're available to assess patients very, very quickly. The rapid response team, when you start having a patient who's having dyspnea, the nasal flaring, they need more, sometimes more than just the respiratory therapist to come to the bedside. They may need medications as well to resolve the underlying cause of the dyspnea. Exertional dyspnea is shortness of breath with activity. So if you are running up from the ground floor up to the third floor of this building, if you were actually running, you would have exertional dyspnea, but normally all of that goes back to normal within a minute or so. Exertional dyspnea in patients who have lung disease, it may be so severe that they can barely walk a few steps from the bed to maybe the restroom, and they're so out of breath that they can hardly make it. Orthopnea is that the patient can only breathe sitting upright or standing, and they use all of their accessory muscles. That patient in that picture that we looked at in the other module, that patient had orthopnea. Orthopnea means that the patient is taking that tripod position. Okay, they have 3 points in contact with the surface. They're sitting on the bed, their feet are on the floor, and their arms are on an overbed table with pillows on it. That's usually what they call the tripod position. The patient sitting at the bedside in a chair, perhaps, could be sitting in the bed. Those are the patients who need 3 or 4 pillows if they're laying in bed. They cannot lay flat to breathe, so orthopnea. What kind of patients would be most significantly affected by orthopnea? Those COPD patients, those emphysema patients. Okay, we already covered a lot of this in 101L because you needed to learn how to assess patients. So normal breath sounds are the 3 that are listed: bronchial, bronchovesicular, and vesicular. The bronchial breath sounds are heard over the trachea. So when you go home tonight or next time you have your stethoscope handy, place it over your trachea, and you can actually hear that it's a hollow tube, very harsh kind of sound. It's very high-pitched and a loud, hoarse type of sound. Bronchovesicular are sort of moderate breath sounds, moderately pitched breath sounds. They're equal on inspiration and expiration. And where do you hear bronchovesicular breath sounds? The peripheral lung is vesicular. Where do you hear bronchovesicular? Between the trachea and the periphery of the lung. So the large airway, right? The right and left main stem bronchus. And then the vesicular is heard over the periphery of the lungs, especially at the base. It's very soft, low-pitched, that gentle sighing sound that you've heard when you assess your own lungs. Okay, those are normal breath sounds. If you are assessing breath sounds and the patient is not ambulatory and is not getting out of bed, sometimes you'll see nurses only assessing the anterior of the chest. But if you have someone who's on bed rest, you must assess the posterior side, because by gravity, fluid will settle at the bases of the lungs. So you need to listen the posterior lungs and along the mid-axillary lines to listen for crackles if there's any fluid collecting. Okay. Adventitious breath sounds, meaning abnormal breath sounds. The first one that's listed is And these abnormal breath sounds are primarily in the bronchial tree and the alveoli. Okay, so the first one is stridor. Stridor is a crowing type of inspiratory sound. It's kids who have croup or upper airway obstruction will have a stridor, respiratory stridor. Does anybody know what that sounds like? Can you make the sound? Yeah, kind of. Stridor is,
Like a whistle.
like.
It's like it also happens like right after extubating a patient a lot of times.
Yeah.
You do routine assessment.
So it's a very, very recognizable sound. Once you've heard stridor, it's important that you manage patients and watch patients very carefully of respiratory stridor, because if it increases, it'll close their airway and they won't be ventilating at all. So if someone has respiratory stridor due to inflamed or edematous vocal cords, what is the intervention? An intubation often will be, well, it may not be possible to intubate those patients if their vocal cords are so edematous that you can't get the endotracheal tube in place, can't get it through the vocal cord. So what do you need to do? Cricothyroidotomy or a tracheostomy? Yes. So wheezing is a very high-pitched musical sound, usually on expiration, although it can be on inspiration and expiration. And wheezing is caused by air flowing through very narrow passageways. So patients who have asthma, you would hear that wheezing. If you have a patient, and emphysema as well, those patients will have wheezing in many cases. If you have a patient who's wheezing tremendously and then it suddenly stops wheezing, that's considered a need for emergent attention to that patient. They may have an obstructed airway. Okay, crackles used to be called rales, and we hear crackles in patients who have fluid in their alveoli. So crackles used to be called rales, and it's air passing through fluid or through mucus in the alveoli, in the airways, where gas exchange takes place. So if you have long enough hair, and you take some of that hair and you rub it between your thumb and your finger, that's what crackles sound like. So crackles is air passing through fluid or mucus. And you can have coarse crackles or fine crackles. Those mannequins in the skills lab, program them to the different types of crackles that you might hear in the airway. So crackles, if it's air passing through fluid or mucus, what are some of the interventions? What are you going to do if you hear crackles? Set the head of the bed up. That's always a good thing to do if somebody has breathing problems. They may need suctioning. But if they have crackles and it's due to pneumonia, and it's only one-sided, for example, what are you going to do? Rotate the patient, turn them from side to side. We also give them a little gadget that's called an incentive spirometer, and that promotes very effective deep breathing to allow the patient to be able to cough up some of those secretions they might have in their airway. So crackles may also be eliminated if it's due to congestive heart failure with Lasix, giving the patient diuretics in order to get rid of that excess fluid, depending on what the underlying causes of the crackles. Gurgles are also called bronchi, and gurgles are caused by air passing through secretions in the larger airways usually. It's low-pitched, kind of a gurgling sound, and if you hear bronchi, if you ask the patient to take some deep breaths and then cough, and then you auscultate again, if they're gone, that's a pretty good indicator that they're bronchi. You really can't cough away crackles because it's in the alveoli. That's a good indicator that the cough was infected and those secretions have been coughed up out of the airway. So air passing through fluid or mucus, crackles, air passing through secretions in the large airway would be gurgles or rhonchi. A pleural friction rub can be heard during inspiration and expiration. It's kind of a grating or a creaking sound. If you rub your thumb and your index finger together and listen to that sound, that's sort of what a pleural friction rub sounds like.
Like two balloons as well.
Yeah, like squeaking. It's due to fluid in the pleural space, and the lining is inflamed. There's usually a layer of fluid in there that keeps it moving very smoothly without any sound. So then you hear that, those two surfaces rubbing together, and I think that's a good analogy, those two balloons that you sort of rub together. A pleural friction rub, if the patient has that, the patient will be complaining of pain with breathing, chest pain. So normally, if a patient has any kind of chest pain, we immediately jump into action, and we always assume, if a patient has chest pain, that it's cardiac in origin. So if you have a patient who suddenly develops chest pain, we will take whatever the protocol is for chest pain, so they would get an EKG, labs would be drawn, we would just monitor them to see if they're having any sort of underlying problem with their heart function. A pleural friction rub causes chest pain, so they would do that first. But if it's a pleural friction rub and the cardiac involvement has been ruled out, you will know that it's due to pleurisy probably. So if a patient has a pleural friction rub, they will complain of tremendous pain in their chest while they're breathing. So it's breathing associated, whereas chest pain, cardiac in origin, is often not, generally not influenced by the breathing, the inspiration, expiration. So pleural friction rub causes chest pain. The next slide talks a little about, we're talking about gas exchange now, so if you're hypoxic, hypoxia is inadequate oxygenation of tissues. The signs of hypoxia are increased respiratory rate and heart rate, that restlessness, anxiety, decreased level of consciousness, particularly one of the early signs of hypoxia in older adults. So if you have a patient who was very awake and alert, and it's an older adult, and now they have a change in LOC, maybe they're not as responsive, or they're becoming very restless, and it's in the middle of the night, instead of medicating them with maybe a medication to allow them to sleep, get your little pulse oximeter out and measure what their O2 stat is. If they are becoming hypoxic due to whatever, maybe they had pain meds or respiratory, their breathing has become more shallow, that may immediately affect their LOC if they're older adults, especially those who already have underlying respiratory disease. So before you medicate them for restlessness, check their O2 sats with pulse oximetry, and if it's okay, then you can go ahead and medicate them. Some of the causes of hypoxia: ventilation, perfusion mismatch. We talked about ventilation is the airflow, the perfusion is the blood flow. If there's any mismatch, then you have issues with not getting enough oxygen to the tissues. High altitude, because high altitude has less oxygen in the air. Anemia causes hypoxia as well. How does anemia cause hypoxia? Because the hemoglobin carries the oxygen. So if you have anemia and less red blood cells for whatever reason, then your oxygenation is affected as well, which could cause hypoxia. So keep in mind that whenever anyone is hypoxic, we need to intervene fairly quickly with any sort of respiratory problems. Remember, airway, breathing, and then circulation. So if the patient has hypoxia and you measure their O2 sats with pulse oximetry, what would you do immediately? Patient's becoming hypoxic, you got 92 reading on the pulse oximeter, normal is 93 to 100. What are you going to do first? Apply O2. Yes, you need an order for O2? Yes, it's a drug, but can you apply it and then get the order? Yes. So if the patient becomes hypoxic, set them up in bed and apply the O2. You can probably do those two things almost concurrently. Keep in mind that the cerebral cortex, your brain, can tolerate hypoxia for only a very short period of time, and that's 3 to 5 minutes. And some patients, if they've been hypoxic, really hypoxic for more than 5 minutes, they may have significant long-term effects of that. The next slide the word sounds very much the same. Hypoxia, lack of adequate oxygenation in the tissues. Hypoxemia is lack of adequate oxygen in the arterial blood plasma. So emia meaning the blood, right? Hypo, oxygen in the blood. Too little oxygen in the blood. So we measure that by the definition is an arterial oxygenation of less than 88 millimeters of mercury. And the PaO2, the partial pressure of arterial O2, again, that is obtained with blood gases. You need a sample of blood from an artery. In critical care, the nurses will draw it or the respiratory therapist will draw it. Outside of critical care, it's generally always the respiratory therapist who draws the blood. Or the lab, I think lab techs do as well. Yeah. If you have a patient who's hypoxemic, they have a low level of required oxygen, low hemoglobin, hypoventilation, or some disease process going on that's causing their hypoxemia. And hypoxemia causes CO2 to build up in the blood. So what would cause a CO2 buildup in the blood? What are some of the things that could cause hypoxemia? Not enough oxygen in the blood. What are some of those causes? What would the patient have, perhaps? CO2 poisoning, maybe. We don't see much of that. What else? GI bleeding, because they've lost so much blood that they don't have enough oxygen carrying capacity to oxygenate all the tissues and organs. Okay. What would cause that? Okay. So what concurrent vital signs would you see if they have bleeding? What else would you be assessing? Drop in blood pressure, increase in heart rate, right? Increase in respiratory rate. Patients who have COPD will be hypoxemic. Chronic obstructive pulmonary disease, those patients who have emphysema. Patients who have tumors in their lungs may become hypoxemic. Pulmonary embolus, you have severe hypoxemia if you have a very large pulmonary embolus. And then patients who have, you'll learn about in the 4th semester, adult respiratory distress syndrome. You'll see patients with ARDS in the critical care unit. So what are you going to see in terms of signs and symptoms? Cyanosis. Where do you check for cyanosis? How do you determine, if you're going to document cyanosis, that the patient has, in fact, that the patient is cyanotic? The nail bed, the mucous membranes of the lips, and the mucous membranes of the eyes, okay, and the soft palate. Restlessness. Again, that patient that I mentioned who may suddenly get restless and they were okay earlier, check the O2 sat before you treat them or medicate them for restlessness. They may have confusion, very dusky skin, nail beds and mucous membranes would take on the bluish color, so they would become, what's the color, what's blue called? Cyanotic, so they would have cyanosis. Okay, another different term, hyperhypocapnia. Hyper, too much. Capnia is CO2. So too much CO2 in their respiratory system. It's usually from hypoventilation. So we already know what causes hypoventilation. So if you have a CO2 level, a partial pressure of arterial CO2 above 45, again, we obtain that from a blood gas, that would be the definition of hypercapnia. It's always accompanied by hypoxia at room air. Okay, so very low O2 causes a high CO2. Okay, hypocapnia is from hyperventilation, those patients who are so anxious they're hyperventilating, blowing off all their CO2. And that definition is the CO2 is less than 35, and the most common cause is that anxiety. So you have them breathe into a bag, so they're rebreathing some of their exhaled air to bring that CO2 level back up. If you have a patient who has hypo or hyper, especially hypocapnia, or even if it's hypercapnia, if you're standing at the bedside and the patient's having breathing problems, first of all, you never leave the patient. They're very anxious if they have any sort of respiratory issues. And try to have the patient look at you and make them breathe with you. It's amazing how effective that can be. So tell them, look at me and breathe with me. And so you're breathing at a regular rate and a regular rhythm. Have them look at you, tell them you'll stay with them. And especially if they're anxious, they will slow down their breathing and they'll recover fairly quickly. So stay with patients in any case who has a respiratory problem. Don't leave their bedside, and then have them breathe with you and try to get back to a regular rhythm. Maybe they're breathing too shallowly, if they're hypercapnic, but see if you can't get that rhythm, that respiratory pattern to change back to a semblance of normal. Okay, we're going to take a look at some of the signs and symptoms of respiratory distress. So coughing is the first sign of respiratory problems, always. So if you develop a cough, it's generally the first sign of a problem. I'm laughing because I'm always coughing. That coughing could be acute, or it could be chronic, and it could be a dry cough or a very productive cough. But whatever it is, coughing is a first sign of a respiratory problem. So post-op patients who need to get their lungs to re-expand following anesthesia, you need to turn, cough, and deep breathe them. So TCDB, you'll see an order. Turn, cough, deep breathe every hour or every 2 hours. And that deep breathing permits expansion of the lungs, and the coughing promotes removal of secretions. Some of these post-op patients, if you're auscultating their lungs, may have crackles. I just mentioned that the definition of crackles is fluid in the alveoli. In these post-op patients, you hear crackles because part of their lung, an area where could be just a small area of the lung space, those alveoli have collapsed due to anesthesia. So those patients who are breathing deeply, when they're taking those deep breaths, if you're auscultating, you may hear crackles, and the crackles are due to those alveoli popping open because they've been collapsed. So post-op, it's really important to get those patients, turn, cough, and deep breathe, and get them mobilized as quickly as you can. So if you have patients who have respiratory distress, some of those primary signs and symptoms, again, the first one is coughing. Sputum production is often an indicator of, by just looking at the sputum, what may be going on with the patient in their lungs in terms of what's producing that sort of sputum. If you have really mucoid sputum is kind of white, it's often due to viral pneumonia. If the sputum is, you know what currant jelly looks like, kind of a purplish brown? Currant jelly sputum is often gram-negative Klebsiella pneumonia. If you have a patient who is coughing up pink frothy stuff, they will also have respiratory distress. that means they have pulmonary edema. Okay? I had a student once who had a patient who had a trach. This was when I was teaching in the 4th semester. And we assessed the patient together in the morning, and one of the things that you do if a patient has a trach is to keep them well hydrated to prevent those secretions from getting thick enough to occlude their airway, so they can cough it up or you can suction it out. So the student took care of this patient. The patient had a history of heart failure. The patient was fine. When I came back a couple of hours later, I said to the student, "So how's your patient doing now?" And the student said, "I have really pushed fluid, hydrated the patient the patient had a G-tube, gave him lots of free water, and now let me tell you that sputum that we're suctioning out is nice and frothy and pink." I nearly passed out. He said, "Excuse me?" Went into the patient was in congestive heart failure from overload of fluid. So if you have pulmonary edema, you have that frothy pink sputum. Luckily, we were able to reverse that. The patient got lots and lots of, what do you think? LASIK. And since the patient had a trach, we had the option of, certainly put him on a vent, but we had to get all the fluid out of his lungs. So you have to understand the patient's underlying medical diagnoses, what the patient's there for, and even though normally we would say hydrate the patient really well, and it'll thin out those secretions, make sure that they have humidified air going over that tracheostomy with a collar. But this particular student could only remember one thing: really hydrate so that when we suction, those secretions won't get really thick. So nearly put the patient over the edge. So pink frothy, not good. Creamy yellow is usually staph pneumonia, that thick creamy yellow stuff. And then if it's that yellow-green, many of us have had upper respiratory infections or bronchitis. That's that yellow-green from chronic bronchitis or acute bronchitis or bacterial pneumonia. Sometimes patients have what's called hemostasis. Hemostasis, hemo means blood, right? Stasis means coughing it up. So you have patients who are coughing up blood. This is not a GI bleed. This is coughing up blood from the lungs, hemostasis. So if you have someone who's coughing up blood, what could be the underlying cause? They could have TB. They could have had chest trauma. What else? Anything else? Lung cancer, and maybe part of that tumor has eroded through some of the blood vessels in the lungs. So you can have hemostasis for a number of reasons. If the patient's coughing up blood, and they weren't before, that's definitely something that you would report as a change, major change in status. Chest pain, I mentioned the chest pain. If it's respiratory related, it's often pleuritic type of chest pain. If it is chest pain and it's new, we always double check to make sure the underlying cause isn't cardiac related chest pain. But if it is chest pain related to breathing, it's usually pleuritic chest pain. So in general, signs and symptoms of respiratory distress would be cyanosis, that bluish color, due to increase in unsaturated hemoglobin. Over a long period of time, we already talked about digital clubbing, long-standing respiratory problems, end-stage emphysema, you would have that digital clubbing. And how do you assess if they have it or not? Put the fingernails together and look for that little diamond shape. And then that barrel chest means that chronic increased residual volume of patients who have COPD will develop a very significant barrel chest, although with age a little bit of rounding of the chest is often considered normal. So if you have a patient who has respiratory problems, you need to manage the patient's dyspnea. So one of the first things you're going to do is, if they're becoming dyspneic and they weren't dyspneic before, is to administer oxygen. So sit them up, administer O2. If you don't have an order for O2, administer the O2 at about 2 to 3 liters per minute. You can apply a nasal cannula, usually to start with, and then call the physician, let the physician know the patient's change in status. Generally, the order will read, administer O2 and titrate it at a level to maintain the O2 sat between usually greater than either 93 or 94%, depends on the hospital, what their number is. So you're going to titrate the level of O2 to coincide with the pulse oximetry reading to maintain it at 94%. Usually 3 liters is adequate unless cardiac arrest is imminent, then you may want to give them a little bit more. Administer medications. What are some of the medications we're going to give them? What's the drug that is just wonderful to relieve the anxiety and it relieves respiratory distress as well? The morphine. So morphine to relieve both the dyspnea and the anxiety related to that dyspnea. Another medication we'll give is anxiolytics to reduce the anxiety related to difficulty breathing. They're often giving steroids to reduce the inflammation in the lungs, the airways. We give them diuretics to reduce the amount of volume of fluid that may be overwhelming the lungs due to perhaps congestive heart failure. Fibrinolytics are sometimes administered. We know the patient for a fact has a pulmonary embolus. They will give them fibrinolytics, which is a clot-busting drug to dissolve the clot to promote perfusion of blood back through the pulmonary vasculature. So those fibrinolytics are used for pulmonary embolism. You've seen used for myocardial infarction as well, but we're talking about the lungs here. So pulmonary embolism, fibrinolytics. We give them bronchodilators to dilate the airways and antibiotics to treat those bacterial infections like the pneumonias. How are we going to position the patient? High Fowler's. So position the patient in a high Fowler's position or sitting at the bedside in a tripod position. Depends on, maybe this patient is one of those chronic COPD patients, and they do better sitting at the bedside in that tripod position with their arms resting on the overbed table, feet on the floor. Suction the airway, PRN, and how do you determine if the patient needs suctioning? You need to assess by auscultating to determine if you hear. You can't suction out the alveoli, right? Okay, so you're going to hear bronchi, right? So you can suction that out. If the patient's able to cough, what are you going to tell the patient to do? See if they can cough it up before you suction them. If they can't generate an effective cough, they're too weak perhaps, then you need to suction them. And how do you know if suctioning was sufficient or do you need to do it again? Auscultate. So we only suction based on auscultating the lungs and assessing for the need if you're hearing adventitious breath sounds. Administer non-invasive ventilatory support, and that non-ventilatory support is non-invasive ventilatory support is CPAP or BiPAP. CPAP stands for continuous positive airway pressure, and the BiPAP is pressure on inspiration and expiration. The CPAP is only on inspiration. So you'll see the machine at the bedside for, in med-surg, I think you might see a CPAP machine and not so much BiPAP because those patients need to have other monitoring as well. Teach an assisted breathing technique. So some of those breathing techniques that I already mentioned, to start with, face the patient, have them breathe with you. If they're breathing too fast or not fast enough and they're awake and alert, they can follow instructions, stand with them and have them follow your breathing pattern. You can also teach them abdominal breathing. So remember the costal breathing, the abdominal breathing, and the pursed lip breathing we mentioned. So abdominal breathing, how do you teach that? How do you know they're doing it correctly? Have the patient put one hand on their abdomen. You can have them put the other hand on the chest. Take a deep breath, and you want them to just puff out their abdomen as far as they can on that deep breath. So working with their abdominal muscles and getting that diaphragm to drop down as low as possible to fill the lungs with air. You have the patient inhale slowly and deeply through their nose. Okay? And then while they're doing that inhalation through their nose, having that abdomen protrude as far as they can, just bring in as much air as they can. And then they tighten their abdominal muscles, and then they press firmly inward and upward on their abdomen, trying to get the lungs to expel as much air as possible. And while they're exhaling through pursed lips, so that's looking like they're whistling. Okay, and the other was the pursed lip breathing, inhaling through the nose for about 3 seconds, hold it for a few seconds, and then exhaling through pursed lips for about 6 to 7 seconds. So exhalation is twice as long as inhalation. And then using non-pharmacologic measures. What are those? What could you do? Coughing technique. Instead of spirometer. Very helpful. Chest percussion, yes, but respiratory usually does that. But nurses used to do that routinely on patients. But yes, very helpful to get those secretions moving. Anything non-pharmacologic measures that you as a nurse could do? You have a patient who's short of breath here, a person who has issues with hypoxia, a patient who's dyspneic. So what else could you do to make things better for the patient? Spin them up. We already talked about positioning, but what else can you do for these patients? Any activity, in many cases, the patients have really severe respiratory distress. Anything you make them do, or ambulation or moving around, will cause more distress. So what can you do as a nurse to facilitate their comfort in terms of their respiratory system, the breathing pattern? You're the nurse. What are you going to do? Okay, making them comfortable. Having a call out within reach, assisting them with their ADL, instead of putting that wash basin in front and saying, now wash, take care of your bed bath yourself. Have them wash their hands and face. Maybe you do their back and their legs, their extremities, to help them out so they're not getting so short of breath. What else? Foot massage. Sounds good. Yeah, and what will that promote? Relaxation. So you can teach relaxation techniques to the patient. Some of that is guided imagery, or provide something for them that relaxes them and helps them to sort of take their mind off of this terrible respiratory distress they're having. What else? What else will help them to kind of get a sense that they can catch their breath a little better? Put a fan in the room. You'll see lots of patients will have a fan in the room. Just that movement of air makes them feel like they can breathe better. Anything else? These patients are really anxious, so you need to provide emotional support for them. Okay, here's the slide that sort of shows what I just said about the abdominal breathing. Inspiration, trying to get that diaphragm, as the air flows into the lungs, dropping the diaphragm down as low as possible to provide maximal expansion of their lungs. And then on expiration, pushing on their abdomen towards the diaphragm to allow and to promote optimal exchange of that air to get it out of the lungs on expiration. That first lip breathing, remember, breathe in, inhale for about 2 seconds through the nose, and then exhale through pursed lips for 6 to 7 seconds, so double the time of inspiration. And what's the purpose of pursed lip breathing? Why do we teach that? The what? Perfusion. No, we're looking more at gas exchange. Not the perfusion is the blood flow, which is part of getting enough oxygen into the lungs. But why are we asking them to do pursed lip breathing? Why is it effective? Yes, allows the oxygen that they've inhaled in the air to be in contact in their alveoli to promote that gas exchange, and hopefully they have good perfusion to promote their breathing overall, their gas exchange. Okay? Yeah.
Part of that, I'm just saying, like when they have a patient taking a breath in the nose and then blow bubbles.
Blow bubbles?
Yeah, my grandfather had chronic breathing, that's what they taught him. Breathing slowly with his nose and then blow bubbles with his straw, a cup of water.
Oh, has the same effect because you're pursing your lips, and instead of just exhaling into the air, you're blowing the bubbles out, and you can actually get a visual response of how effective it is. So that's a good idea to do that for patients. Generally, we don't do it for our patients in the hospital, but I'm sure at home that they're taught to do that. How about respiratory? Do you have them blow out through a straw into a cup full of water?
I do whatever they'll do. It's a bargaining.
Yeah. Whatever works for the patient, that strategy, then sometimes patients need that visual feedback that in fact it's working.
That's a great idea.
Yeah, I haven't done that, but I think that's an excellent idea. So these are lots of nursing diagnoses. Remember that anxiety is at the top of the list. You need to stay with that patient because if they are unable to breathe, they become very anxious, and they need someone at their bedside to talk to them, keep them calm, and let them know we're doing everything we can to get them to breathe better. So you have impaired gas exchange, ineffective airway clearance. If you have a nursing diagnosis of ineffective airway clearance, you have to have some evidence that they have secretions that need to be coughed up or suctioned out. That activity intolerance that patients have with severe respiratory disease, they can hardly walk 2 feet without just really having to stop and catch their breath. That's related to the imbalance between the oxygen supply and demand. The oxygen supply is so low, demand becomes greater when you have activity. So they have activity intolerance. Associated with that, they always have vital sign changes that need to be as evidenced by. And then, of course, ineffective breathing pattern, whatever that underlying cause may be. Okay, so patients who have respiratory problems, you will see lots of different kinds of diagnostic tests that will be ordered. So if you have a patient who has a chest x-ray ordered, what do you think might be the reason for the chest x-ray? To see if they have pneumonia. Anything else? If they have TB. If they have a pneumothorax, a collapsed lung. And the what? Check for pleural effusion. Okay, yeah. Anything else? Okay, what does the chest x-ray show you? What's on the x-ray? If they order a chest x-ray and you were to look at it on viewing screen, what do you see? The lungs, and what else do you see? The ribs. So you can see if they have a rib fracture that caused the lung to be punctured due to some sort of trauma, right? What else does it show? The trachea and the heart. So if they have CHF and it's the chest x-ray would show a very enlarged heart in many cases, a failing heart. So chest x-ray, very easy. What kind of instructions do you have to give them before they have their chest x-ray? Yeah, they just need to take their breath and hold it. Often it's done at the bedside, a portable chest x-ray. CT scan is a scan that visualizes the pulmonary structures. CT stands for computerized tomography, same as a CAT scan. VQ scan is also called a lung scan, and VQ, I don't know why it says VQ, it's a ventilation perfusion scan, also called a lung scan. So 3 names: VQ scan, ventilation perfusion scan, or a lung scan. Okay? It's airflow and blood studies. What they're doing is they inject a radioisotope into a vein, and then they have the patient inhale some sort of a radioactive gas. So they're looking at the blood flow, ventilation, the airflow, ventilation, and the perfusion. So they're trying to figure out, is there a problem with both, or is there a problem with just ventilation or just with perfusion? If it is not conclusive, sometimes these ventilation perfusion scans are not conclusive, and if that's the case, they will follow it up with a pulmonary angiogram. So a pulmonary angiogram is, they inject a dye and they determine whether or not the patient has a pulmonary embolus. So definitive for pulmonary embolus would be that pulmonary angiogram, visualizing actually where the clot's located. Okay, pulse oximetry is a non-invasive monitoring device. Who has not seen what a pulse oximetry measuring device looks like? It's that little probe that goes on the finger, and so either handheld or at the bedside, it will show you the patient's oxygen saturation at the periphery where that monitoring device is attached. It could be on a finger, it could be on a toe. Sometimes they tape it on the nose or on an earlobe, so different types of devices. The ones that most of you have seen are the ones that clip on the finger, right? Okay, so pulse oximetry is normal is about 93 to 100. Sometimes they say 94 to 100. And it gives us, the number reflects the oxygen saturation. It's the light that is absorbed by the oxyhemoglobin that's flowing through that, the finger, the toe, or wherever that sensor is applied. So 93 or 94 to 100 is normal. If it's less than 93, immediate treatment with oxygen is required. So the order you get oxygen will always be maintain that O2 sat, the pulse oximetry, at 94 or greater. Sometimes they'll give you a higher number. If your pulse oximetry number is less than 70, it's life-threatening. So important not to let it go that low. And generally that's intervened long before it drops down to 70. If you're using pulse oximetry and you're putting on the patient's fingers or toes, if you have a patient, a female patient in most cases, that has nail polish on or has synthetic fingernails, you can't put it on synthetic fingernails or on someone who has nail polish on. So you have to either take the nail polish off. You can't, usually we don't suggest you take the acrylic nails off. You may have to find a different site. Okay, if you have a patient who's later on, when you have these patients and they have an arterial line in maybe their right radial artery, they have an arterial monitoring line in, don't put the pulse oximeter on the side where the arterial line is. And you'll see those patients in critical care who generally don't have arterial lines on the med-surg floors. Don't put the sensor on the thumb, or if they have a real edematous hand. So it's always on the fingers, but not on the thumb. Explain the procedure to the patient if they don't know. If you have a patient who is severely anemic, generally those pulse oximetry readings may be inaccurate. Severe anemia, it's not accurate, so it has to be pretty low. It's helpful if you're going to put a sensor on a finger or a toe, check for capillary refill first. If there's good cap refill, it's a good site to put the sensor on. If you have a patient who has pulse oximetry monitoring devices on, you do need to remove them every couple of hours just to make sure there's not excessive pressure on the finger, or whatever the policy is. If it is continuous monitoring at the bedside, they will set the limit where it'll alarm when it goes below a certain percent. Do not ever turn alarms off. If the patient says, I think it's driving me crazy, it's better to have that alarm going off and having somebody respond to it than to have the patient's CO2 level, their oxygenation level drop so low that it endangers the patient. So never turn off alarms, ever, on anything. You know how you can silence alarms? Don't do that. Compare the O2 sat readings that you get. It's called SpO2. Okay? SpO2 is the same as pulse oximetry. We usually rotate the sites of where we place the sensors. So pulse oximetry, very easy to do, very good indicator how the patient is doing. It doesn't eliminate the need for blood gases, but it has tremendously reduced the number of sticks we have to make on patients to figure out what their oxygen saturation is. Pulmonary function tests are usually, they evaluate lung function. You don't have to know exactly what they are. They're usually done by respiratory. And they're looking at the volume of air that's inhaled into the lungs, what the total lung capacity is compared to the volume that the patient is inhaling, and they're looking at just airflow rate. Bronchoscopy is a diagnostic test where a scope is inserted into the lungs to visualize the main stem bronchus. And if the patient has a bronchoscopy scheduled, they need to be NPO ideally for about 6 hours before it's done. The patient then has the bronchoscopy done, they'll come back to the floor. It's your job to take all food and drinks away from the patient's immediate environment until you check their gag reflex. You'll take a tongue depressor and check to see if they gag. If their gag reflex is not returned and is not intact, don't give them any food or fluids until that has returned. Otherwise, their airway is not protected and they can aspirate whatever it is they try to swallow. Thoracentesis is a large needle that's put into the chest to draw off excess fluid. So patients who have lots of fluid in their pleural space in particular, we see a lot of end-stage cancer patients who will end up having a need for thoracentesis. So they'll put a large bore needle in, hook it up to one of those vacuum containers, and then drain out the fluid. I have seen 5 liters being removed from a patient's chest with a thoracentesis. And the patient suddenly feels better, they can breathe better. All of that fluid is just diminishing their lung capacity. So thoracentesis is helpful often, like I said, in patients who have end-stage cancer. A pulmonary angiogram, I just mentioned that, if the VQ scan is not conclusive, they will do a pulmonary angiogram to make a definitive diagnosis of pulmonary embolism. Lung biopsy is generally done while they do the bronchoscopy, if a bronchoscopy is being done, and they're getting a specimen for diagnostic purposes, whether or not perhaps the tumor is malignant or non-malignant. And then fluoroscopy is an x-ray that shows movement of the lungs and the heart on the screen. It's a live picture of what the lungs and the heart are doing. Fluoro can be done at the bedside, generally done in interventional radiology, but if they're doing fluoro at the bedside and you need to help, hold the patient or do whatever, make sure you put on a lead apron. Lots of radiation with fluoroscopy. Okay, some of the lab tests that are associated with respiratory disease, CBC and hemoglobin. Okay, so CBC is a complete blood count. In particular, we're looking at RBCs to determine and hemoglobin to determine the oxygen carrying capacity of the blood. Patients who have respiratory disease, what do you think happens to their RBCs? Increase or decrease? How many say decrease? How many say increase? How many say I don't know? Okay, think about physiologically. If you have long-standing respiratory disease, what's the body going to do? It's going to compensate by producing more red blood cells, so there's more oxygen carrying capacity. So patients who have long-standing respiratory disease will have higher levels of RBCs, and it's called polycythemia. You need to know that term. Polycythemia. High numbers of RBCs to the body's compensatory mechanism to increase respiratory carrying capacity. Polycythemia. Would we look at WBCs as well? And what would that indicate? Infection. So if they have pneumonia, you would see, in most cases, an elevated WBC as well. In older adults, remember, they may not have significant elevation of WBCs with an infection. Sputum collection, really important in respiratory cases. We want to get a good sputum specimen so that we can determine if there's an organism that's causing the pneumonia, for example. So sputum collection is ideally done in the morning after they wake up, so that whatever secretions they have in their lungs, the patient can generate a sufficient cough to cough that up. We don't want spit. We want the stuff that's coming out of their large airways. So we want sputum. Have the patient breathe, take some deep breaths, like 3 deep breaths, and then cough, and see if they can cough up that sputum from their lungs. And then you collect those secretions generally in a sterile container. Men do a whole lot better job of coughing up sputum than women do. Sometimes we have to actually suction some patients if they can't cough it up. We'll have to do nasotracheal suctioning to get that sputum specimen. So in the morning, best time. Gram stain and cytology would be used just quick and dirty to see if they have TB. Cytology would be to see if they have malignant cells in their sputum. We usually send it for culture and sensitivity as well. The culture is what's the organism that's in their sputum that's causing their disease process. And then the sensitivity will show sensitive or resistant to a list of antibiotics. So we'll get a culture and a sensitivity to determine which antibiotic would be most effective for that, whatever the organism is. Acid-fast bacillus is a quick test to test for TB. However, the definitive test for TB is culture and sensitivity. AFB, acid-fast bacillus, is not specific to TB. So if you want to have an actual diagnosis of TB, you have to have a culture and sensitivity. And what does that grow out if you have TB? Mycobacterium tuberculosis. So definitive for TB, you must have a culture and sensitivity. The other test that's done is an arterial blood gas. You're not going to do that, but if you have a patient who has an arterial blood gas order, it's not uncommon because you kind of hover around the patient. When whoever draws that blood specimen, they'll say, can you just hold pressure on this? If you're asked to hold pressure on an arterial stick, remember it's the high pressure side, arteries. It's not a venous stick that you just sort of slap on a Band-Aid and that's good enough. You need to stand there and hold pressure. If it's your patient, you will know if they're on anticoagulants, if they're on heparin, or that low molecular weight heparin. If that's the case, you need to hold the pressure even longer. So generally, the standard is about 5 minutes that you're holding pressure on a normal patient who has good coagulation. If you know they're on anticoagulants, you may have to hold pressure longer. Hold continuous pressure. Don't release it to see if it's bleeding. hold continuous pressure. We want that hole that's been punctured into that artery to seal over, and we don't want a large hematoma developing where that blood vessel is going to leak. So hold pressure nice and firmly for 5 minutes if you're asked to hold pressure. And you know it's a radial, if it's an arterial stick, it's either radial or brachial. If they can't get either one, they may do a femoral stick. But for the most part, they'll start with the most distal and then go closer to the larger artery. Femoral sticks, make sure you hold pressure again. You don't want to have a huge hematoma. That's a large artery. It readily could leak if you don't hold enough pressure. Blood gases are arterial. I don't test you on blood gases. That'll come, I think Brian does the whole thing on arterial blood gases. Just know it's one of the lab tests for respiratory patients. Okay, I'm going to take a break and give you a 10-minute break, and I'll go get that transponder so we can do those questions. Rồi này không đâu được lần nữa.
You guys have your clicker? Give this first question a try. All right.
So answer the question.
Pick your correct answer, put in, turn it on. What channel? I think it's 41. 41. I think. Okay, something's working, we gotta respond. What channel? Oh, no, that's not my answer, I'm just clicking 41. 46. I think it's 40. This one's blacked out. That's all I've ever done for you. Here's one with the dead battery. Oh, we got 8 responses, so somebody's figuring it out. You need to... No, it's not. Coming up, so you may need a new battery. How that okay? But anyway, so... How many do you have to turn this How many don't have clickers?
So we know how many not to count.
So 2, 3, 4, 5.
Okay. So we should have about 30 answers.
So we should at least get to 20 answers, so you gotta make a decision at some point in your life. No, it won't. It tells us up there in that top corner that we have 17 responses. And so, what I do do is when I get at least a 50% of the class, then I go ahead and reveal the answer. So it's your call when you want to do that. You're at 20. Then you click on that
So 95% you got the answer correct.
And the one thing I put down is nobody ever admits to the one where it's wrong. So you want to try this now? Okay, next question is up. Now you have to open up. I couldn't read your questions right after. My name is Dave Brown. I don't use this question. I stopped the whole week. So I started and stopped over. Okay, how many we got? We can do better than 9.
So you can't control what the answer is.
Yeah, remember this is not a group activity most of the time.
So you can't control on the answer.
If 3 people give us an answer in combination, maybe only one of those persons knew the information and the other 2 are just kind of guiding on based on that student. And we'd really like to clarify the information rather than 2 students going away not understanding why they didn't get the content. So it's really important that you answer on your own. Okay, you're at 25.
Who has not answered with a clicker?
Sometimes you just gotta make your best guess.
We're going to close the
Eliminate 2
answer
answers
now.
and then choose the best.
Okay, all right, so now we'll...
Okay, so then, maybe not quite so clear what the correct answer was there.
Okay, so the question was, the patient who is diagnosed with TB has to go to radiology. You're the nurse. You're going to send the patient to radiology. So what action should you take? Number 1, A was apply a surgical mask to the patient. That is the correct answer because a surgical mask filters exhaled air, right? The patient already has TB. So A was the correct answer. B is apply a mask and gown to the patient. It didn't say what kind of a mask, and the gown's not required because it's airborne. Answer number 3 was apply an N95 respirator mask and a gown to the patient. The respirator mask filters inhaled air to prevent someone from getting TB. The patient already has TB. And then answer 4 was notify X-ray so the staff can be sure to wear a mask when the patient arrives. You put the mask on the patient only. Okay? All right. Next one. Okay. You can't share answers. Oh. Okay. how does that work? Okay, is there anybody who has not yet answered?
Just a second. We need to figure out how we're gonna handle that, and Alex will get back to you on that. We'll go back your next letter. We have to talk with the coordinator and find out if we're gonna replace the battery, if we replace the battery, just commitment, so you guys have to deal with it.
So we have answers all over the map here. So the question was, you have an immunosuppressed patient, immunosuppressed, meaning their immune system is not effectively able to deal with diseases or organisms that might be in the patient's environment, right? They've had radiation therapy, they've had chemo, for whatever reason. So the question was, a patient is immunosuppressed is admitted with neutropenic precautions. So you have to place the patient in neutropenic precautions. So you should ensure, you the nurse are assigned to this patient, and that's the order, place in neutropenic precautions. So what are you going to do? The first one is an isolation gown is placed on the patient if he leaves the room.
You want me to show that?
No. Second one was fresh flowers are placed in the room. Make sure there are fresh flowers. No. They are not allowed to be in the room. Okay? The third one was the patient is placed in a negative pressure airflow room. No. And the fourth one was the patient is placed in a positive pressure airflow room. Yes. Negative pressure is for TV. That means when the hallway doors open to the patient's room, the air flows from the hallway into the patient's room so that the community air that we breathe in the hallways doesn't become contaminated with anything leaving the room. With neutropenic precautions, we don't want anything that's in the contaminated air in the hallway. That's normal and okay for us. But that patient is so immune compromised that they may become ill from something that would normally not affect any of us who have a healthy immune system. So they're in a positive pressure airflow room. When you open the door, the air flows out of the room, so none of the air from the hallway flows into the room. So they're in a positive pressure airflow room. Okay? Next question. This is from last week's model. Remember the content here? Okay. Here. 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 Okay, next question.
You got it?
Thank you.
Good luck, guys.
Thank you. That's Dale Mixer, 4th semester. Thanks, Dale. Okay, the physician is about to defibrillate a patient and says in a loud voice, clear. The nurse immediately Anybody who has not yet decided the answer? Wow, you learned that well. Okay, so the answer was, you stop CPR, you step away, make sure everybody else is stepping away and not touching the bed. It's one of your CPR questions. Okay, last question. So I think you may have to click multiple answers. Not sure how that works, that's why I added this one, to see how that works with multiple answers. You can't?
One at a time.
Okay. You do all of them I don't know. All of them and then enter? Or one at a time?
I did it one at a time.
He did it one at a time. First time I'm doing this, so I'm lucky it works with Dale helping out.
What is feedback?
What is what?
Feedback in the right corner. Oh, yeah, another computer.
I don't know.
Feedback.
Everybody done? Yeah?
Hi.
Okay, the answer was all of them. Okay, so if you're the patient, the machine is always on even when the patient isn't in there. All equipment has to be MRI compatible. Remember the example I gave you about the O2 tank that was attached to the gurney and flew out of the container and patient with pacemaker cannot be scanned because it's metal. And the last one was IV pumps and monitoring devices cannot be brought into the MRI. They have like little opening sleeves that you can put the tubing through, but not the machine. So that's the answer to all of them. Can you bring a what? A visitor into the MRI room? Yes. Generally, sometimes with children, but usually children have anesthesia, giving them some anesthesia so they lay still. I've seen on occasion that a family member could go in there with a child, but generally no, but you can, yes. You have to give everything out of your pockets, make sure there's no metal on you. The same criteria would apply to the visitor as it would, but generally it's avoided as much as we can, not allow that person in there. Lots of radiation with MRI. Okay, we're out of time. I appreciate your attention with these clickers. I'll start incorporating questions into the lecture so you can use your clickers throughout the lecture. See you tomorrow. Did I tell you something? No, it's due tomorrow. Do the case study. You're not going to get graded on it, but we're going to discuss it.
Oh, you want to do this? Papel?